Welcome to part 2 of the cervical spine. This is a continuation of part 1. So in this presentation we're going to look at cervical spine trauma and look at a range of injuries and conclude with how you assess the stability of the cervical spine.
Atlanto-occipital disassociation. This covers both subluxations and dislocations. It's most common in pediatrics. In adults, it's due to major trauma, usually from motor vehicle accidents, and it is nearly always fatal. So you get malpositioning of the occipital condyles in relation to the superior articulating facets of C1. You get cervicocranial prevertebral soft tissue swelling. It's a very significant injury. Good way to check alignment of the occiput in relation to the cervical spine. If you come down the clivus here, the clivus should be in alignment with the posterior third of the vertebral body of C2. We can see here that the clivus is actually in alignment with the anterior cortex of the vertebral body of C2, indicating that there's malalignment. So what is this? It's disassociation, where the atlanto-occipital joint, how distracted. We can see that the occiput is distracted from C1. Here we have our Jefferson fracture. Our peg view is the best view to appreciate a Jefferson fracture. It's caused by an axial force. So classically, our patients dive into a swimming pool and they hit their head on the swimming pool floor. And the axial force drives up, or down I should say, into the cervical spine, into the body of C1, and the axial force causes C1 to burst apart. So what do we look for on our peg view? We're looking for alignment of the lateral mass of C1, which should be in alignment with the lateral border of C2. We can clearly see there is a step off of C1 onto C2 on both sides. So this has burst through the C1 vertebral body, causing it to displace laterally in relation to C2. On your lateral view, your predentate space may be widened if the transverse ligament is affected. So what do we say about that? The predentate space in adults is 3 millimeters or less. In children, it's 5 millimeters or less. 1/3 of Jefferson fractures are associated with a C2 fracture. So when we're checking our C2, look particularly carefully in the body of C2. Check your base of your dens. Check all the way around the dens to make sure that there's all in alignment. So what do we have? It's a fracture, Jefferson, where C1, how, burst. Okay, let's have a look at the Jefferson fracture on the lateral C-spine. Let's assess our lateral C-spine. A is for adequate. Okay, got base of skull on, that's okay, that's good. 1, 2, 3, 4, 5. So we only have 5 cervical vertebrae when we should be able to visualise down to T1. So in the clinical practice, this cervical spine is not adequate. This is inadequate views. You would either need to repeat this view, or judging by the shoulders, you would need to do a swimmer's view. However, in the exam scenario, I don't want you to focus on what you can't see. We're not expecting you to report on something you cannot see. We want you to focus on the area of interest that has been included on your imaging. So in the exam context, don't worry if you can't see the entire cervical spine. Clinically, this is inadequate and you would need to repeat. Okay, S is for soft tissues. Well, unfortunately, due to the overlapping artifact, it's really difficult to see the soft tissue line. So in this image, we'll ignore that. A is alignment. Okay. So we run down our anterior vertebral line, which runs along the anterior cortex of the dens, down the anterior vertebral body of C2, C3, C4, C5. Now you'll notice that C5 in particular has quite a big spur. Don't follow around the spur, otherwise you'll get an abnormal anterior vertebral line. This appearance, this slightly spur-like projection, these are spondylotic changes. This is an osteophyte. So it mustn't be misconstrued as creating a curvature to the anterior longitudinal line. We just go down the anterior bodies, just cut off that little spur and keep following down. So this is a normal anterior vertebral line. Let's look at our posterior line. That's run down the posterior cortex of the vertebral bodies. That's normal. Let's look at our spinolaminar line. That spinolaminar line is pretty good actually. That's normal. The predentate space, normal. Okay, so we've done adequate, soft tissues, alignment. What's next? B for bones. So let's have a quick look at our skull. Check the skull, back of the skull, make sure there's no fractures. Have a look at the mandible, normal. Look at the anterior tubercle of C1. Let's go around the odontoid peg, body of C2. Let's go around the entire cortex of C3, C4, C5. Let's go up the articular pillars. And here, when we look at the posterior arch of C1, we see marked lucent line with disruption to the cortex. This is a fracture. We haven't finished though, so let's keep going. Let's go around the spinous process. Around the lamina, spinous process, the lamina, spinous process. So there's no further fractures, there's just this fracture through the posterior arch of C1. Okay, so we've done bones, now we do C, cartilage, joints. That intervertebral disc space looks good. That one's of similar size, similar size, similar size. Let's have a look at our facets. Normal, normal, normal. So we've got normal intervertebral disc space, normal facet joints. So our abnormality is a fracture through the posterior arch of C1. So what is it? It's a fracture, Jefferson's. Where? C1. How? Slightly displaced. Now we only describe it as slightly displaced on this single view. If you were given 3 images in the exam, an AP, a lateral and a peg view, and the peg view demonstrated lateral displacement of C1 in relationship to C2, then the how would be burst. Okay, so we only describe it as slightly displaced in the context of this single view. Okay, let's move on. There are three types of odontoid peg fracture. Type 1 is a fracture to the tip of the odontoid process. But to be honest, common consensus these days believes that this is actually an unfused accessory ossification centre, os terminale. Even if it was a fracture, it's considered stable. As you can imagine, the lateral mass of C1 sits on top of the vertebral body of C2, and the peg holds the lateral masses in place. And because the fracture only goes to the tip, the odontoid peg can still hold the lateral mass in position. So this is a stable injury. Type 2, fracture to the base of the peg. This is very common. As you can imagine, because the fracture to the base of the peg means that the peg is no longer united and therefore it is unstable. So C1, the lateral masses of C1 are now no longer held in place, and so the peg can move, usually anterior or posterior in relation to the vertebral body of C2. It has a high risk of non-union, so it's often fixed in theatre. Type 3, the fracture now extends down into the lateral masses of C2, and because of that, it is held in place, so the odontoid peg remains stable, and so usually C1 lateral masses are remained in alignment with C2. So let's have a look at a type 2 fracture radiographically, the most common out of the three peg fractures. A is for adequate. While the maxilla does not superimpose the occiput, so you could repeat this to get a better visualization of the odontoid peg. It's not clearly demonstrating the lateral alignment of the lateral masses of C1 with the lateral border of C2. So again, we could have done with making sure that this mouth was open wider to be able to visualize that. So clinical practice, you would repeat this. We don't need to worry about S for soft tissues. So now we need to look for alignment. As we say, can't really visualize it, but actually the alignment looks pretty good. So B is for bones. Let's go around the lateral mass. That's fine. Lateral mass, fine. That's a transverse process, there's no problem. Let's go over the vertebral body, up over the peg, and straight away we can see how we've lost the cortex on both sides. There's a marked lucent line, there's distraction to the peg. This is a great big fracture through the peg here. Come on down. So we've got marked fracture of the peg. C's for cartilage, yeah. The disc space looks fine. Okay, so there's a big fracture going through there. So what is it? It's a fracture. Where odontoid peg? How distracted? Now this only applies to this image, because what we would like to see is we'd like to see the lateral view to see if the peg has displaced, causing either a spondylolithesis or a retrolithesis of C1 onto C2. So you would need your lateral view in order to assess for alignment. So the distracted bit only applies on this view. So, tips and hints. Find the coffee bean, find the anterior tubercle of C1, find the anterior cortex of the vertebral body C2 and the posterior cortex. Measure that distance. Using that distance, you can apply the same distance posterior to the anterior tubercle of C1. Draw an imaginary line. Do the cortexes line up? No, there's a step. Look at your spinolaminar line, marked step. So we know there's a problem here. Okay, let's do the proper assessment. A is for adequate. Okay, we've got the base of the skull on. It was really helpful. We've got the clivus, which is fantastic. We can bring the clivus down and see if it meets with the posterior cortex of the odontoid peg, which it does. 1, 2, 3, 4, 5, 6. So clinically, this is inadequate because we need to see T1. In the exam context though, this is fine. So now we want to look at our soft tissue line. So we come down, this is our pre-vertebral soft tissue line, and it comes round here. So it should be 7 at 2 and 22 at 7. So it's the equivalent of a third of the vertebral body at C2, and it's the equivalent of the 100% of the vertebral body width at C7. If we look, there is soft tissue swelling here. There is bulging of the soft tissue line. This is bigger than normal. This is abnormal. So we've got a positive soft tissue sign. Okay, so A is alignment. So we come down our anterior vertebral line. Oh, there's a step. There's a step there in the cortex. Come on down. No problem there. Let's go up the posterior vertebral line, coming up. Oh, step. So we've got an abnormality in the posterior vertebral line. So we've got 2 steps. So we've got an abnormal anterior line. We've got an abnormal posterior line. Let's go down a spinal lamina line. Yep, abnormal. We've got a step. So we have malalignment in 1, 2, 3 views. B. B is for bones. No fractures in the base of the skull. Mandible looks okay. Anterior tubercle. C over the odontoid peg. There's a fracture. So we've got a fracture through our peg. There's the vertebral body C2, vertebral body C3, 4, 5, 6. Let's go to the pedicles. Let's look at the posterior arch of C1. Let's look at the articular pillars. Let's look at the lamina. Spinous processes. Okay, so now we're after C for cartilage, intervertebral disc spaces are looking really good. Let's check our facet joints. Well, they're kind of narrowed, but they're very sclerotic, so that's due to facet joint arthropathy. Check our interspinous spaces, that's all normal. There's a widening of the C1, C2 interspinous space. Okay, so we can see we've got a fracture to the base of the peg. Let's look at the next view. So what is it? It's a fracture. Where? Odontoid peg. How? Spondylolisthesis of C1 onto C2. So we can see that C1 has moved anteriorly in relationship to C2. So it's a spondylolisthesis of C1 onto C2. So another very common fracture in the cervical spine is a hangman's fracture. Although to be honest, it should really be a hanged man fracture rather than hangman's. And it's caused by hyperextension injury, classically from a hanging, as you can imagine. And you get a bilateral fracture to the pars denticularis of C2. Okay. This is a very unstable injury, so it's important to pick it up. Okay, so let's go through this. A is for adequate. Got base of skull. Excellent. 1, 2, 3, 4, 5, 6, 7. Can't see T1. So clinically, you would need to do a swimmer's view. In this context, though, we will accept it. S is for soft tissue. So let's come down that prevertebral soft tissue line. 7 at C2, or 30% of the vertebral body width. 100% of the vertebral body width, or 22 at 7. And in this case, this is normal. So here we can clearly see how the prevertebral soft tissue line is not sensitive, particularly if the fracture occurs posteriorly. So remember, a normal prevertebral soft tissue line does not necessarily mean it's normal. So A is adequate, S is soft tissue, A is alignment. Okay, nice, we've got the clivus. Let's come down the clivus to the posterior cortex of C2. Yep, great, excellent. So that's in alignment. So let's go down our anterior vertebral line. Oh, there's a step of C2 moving forwards in relation to C3. Normal, normal, normal. Let's go up our posterior line. There's a slight malalignment of C2 onto C3 posteriorly. Let's check our spinolaminar line. Oh, look at that. There's a big step in our spinolaminar line. Let's look at interspinous space. Yeah, there's marked diastasis of our interspinous space between C1 and C2. Okay, so A is for adequate, S is for soft tissue, A is for alignment, B is for bones. Yeah, base of the skull looks pretty good. Let's check our mandible. Yeah, no problem. Our hyoid bone is clearly demonstrated. Check that. With strangulation, you can get fractures to the hyoid. Let's go around our anterior tubercle of C1, over our odontoid peg, around the vertebral body. Vertebral body C3, C4, C5, C6, C7. Right, let's go along our articular pillars. And looking at the pedicles posteriorly. And we can quite clearly see there's a big sharp lucency with a disruption of the cortex to the pars denticularis of C2. articular pillar looks fine. So there's a fracture through the bilateral pars articularis. Let's look at the posterior arch of C1, spinous processes now. And the lamina, spinous processes, lamina, spinous processes. Okay, so we have a fracture, a bilateral fracture through the pars articularis of C2. Okay, so A is adequate, S is soft tissues, A is alignment, B is bones, C is cartilage. Okay, normal intervertebral disc space. Let's check our facet joints, all in alignment. Okay, so we've got normal cartilage. So remember, we can see on the left view the step of C2 moving anterior in relation to C3. We can see the fracture in the cortex, we can see the step in the spinal laminar line. Okay, let's go on. So what is it? It's a fracture, hangman's. Where? C2 pars articularis. How? Spondylolisthesis of C2 onto C3. So we use the 3 columns of Dennis to determine stability. So if there is a fracture that involves 1 column, then this is considered to be a stable injury. If a fracture involves 2 columns, this is therefore an unstable injury. So let's quickly go through the structure of a vertebra. We've got the anterior longitudinal ligament that runs down our anterior vertebral bodies. We've got our vertebral bodies, our intervertebral disc, running along the posterior cortex of the vertebral bodies is the PLL, the posterior longitudinal ligament. And then we have the supraspinatus ligament running along the tips of the spinous process. And we have the ligamentum flavum running between the interspinous processes. So the anterior column involves the anterior longitudinal ligament, the anterior 2/3 of the vertebral body, and the anterior 2/3 of the annulosus fibrosus. Remember, the outside layer of the intervertebral disc is the annulus fibrosus, and the inner squidgy bit is the nucleus pulposus. So our middle column consists of the posterior third of the vertebral body, the posterior third of the annulus fibrosus, and the posterior longitudinal ligament. The posterior column is everything posterior to the posterior longitudinal ligament. So that's your pedicles, your facet joints, your ligamentum flavum, your neural arch, and the interconnecting ligaments. So if we have a fracture through 1 column, stable, 2 columns, unstable.
So that's the end of part 2. We look forward to meeting you again for part 3, which is the final part of the cervical spine.